Okay, Bismillah Rahman Rahim. So today is a session basically related to some cases. In the last session we discussed mainly the anatomical part, radiological anatomy, and now today we're going to discuss mainly about the pathologies. It will not be like in too much details, but I just need to emphasize some of the common pathologies, whether it is trauma related or non-trauma, and which can be useful for your maybe future clinical practices as well. Okay, so before I start, you must have an idea about the fractures, okay, the type of fractures, whether it can be linear, non-displaced fracture, simple fracture, comminuted fracture, open or compound fractures. And then there are like depressed fractures. If I'm just speaking about the skull, there are certain complications which can lead to changes post-traumatic, especially associated with fractures. It can be hemorrhages, it can be tearing of the dura, resulting in like CSF rhinorrhea, CSF otorrhea, or maybe like infections later on. Okay, there are different types of hemorrhages which we're going to discuss. One important point which is mentioned in this slide is like when you are suspicious of the depressed fracture of the clinical significance. So if we have like the skull bone, so this is outer table, inner table, and in the middle it's diploic space, right? So if it is fractured from here, and if it's depressed more than the inner table skull, this is it needs to be corrected. It needs surgical intervention, because if you don't make it, it will cause parenchymal hemorrhages and also like complications regarding the hematomas. So important to identify the depressed skull fractures. I will show you later on. Okay. One other important point regarding the fractures for the skull especially, and in other parts of the body as well, but mainly in the skull, because we have sutures here. How to identify the fractures, whether it is a fracture, suture, or vessel. These three important areas. So the sutures are basically having a zigzag appearance. Okay, like if you see this image, this is lambdoid suture, right? So it has a zigzag appearance or wavy outlines. The fractures are very sharp, like in this image. This one is coronal suture, which is fused. Sagittal suture, you can again see like zigzag appearance here also, but on this side of the parietal bone, we have a sharp linear fracture here. This image shows a depressed fracture. It's typically known as ping pong fractures. So it is depressed inner skull table of the skull, typically seen in pediatric patients. Now in these two images, what you can see, this is the coronal suture, lambdoid suture. Here you can see a very sharp line. If you can see any lucent line, when I'm using the word lucent, it means black. If I use sclerotic, means white. Okay, same like hyperdensity, isodensity, according to the area of or the modality. But here you can see a sharp line or lucent line without any branching pattern. Even if it's branch or branching fracture, you must see the sharp lines. The vessels are more like an irregular pattern. Okay. Now in this image, so this is the recent fracture, and this patient was followed later on. Here this same fracture shows widening of the space because of the little bit chronicity of the fracture. So important is to see if it's getting close or it's showing more diastasis. If it's more diastasis, there are chances that the dura extends through this defect and causing leptomeningeal cyst. Okay, now comes to the hemorrhages. So hemorrhages are mainly two types. One is intraaxial. Intraaxial means intracerebral. Intracerebral means parenchymal. Or diffuse axonal injury. When it is involving the gray and white matter junction, it is called diffuse axonal injury. It has more prognostic value. If it's like extraaxial, there are three types. One is epidural, second is subdural, third is subarachnoid. Okay? Then it's like subgaleal, outside the skull, like in the soft tissue injury. So in brain, we have three types: epidural, subdural, and subarachnoid. Okay, so we have three layers, meningeal layers. One is the dura, the arachnoid matter, and the pia mater. So dura is having outer connection with the bone. Then there is inner dura, and from the inner dura to the arachnoid matter, and below the arachnoid is the pia mater. So if the hematoma is above the dura, limited by the bone, this is epidural. Significance: it is because of the tear of the branches of middle meningeal artery. If it's subdural, because of the bridging veins. Okay, and then the importance of subarachnoid is that it extends into the sulci, okay, and it is causing obstruction to the flow of CSF. Okay, so this epidural hematoma having a convex appearance, this one is having a concave appearance. Okay, and if you see this image here, the sulci are like a different color, but here it is red, so it is because of the subarachnoid hemorrhage. Okay, now in this axial CT, okay, again I'm using the word hyperdense. Hyperdense means if I'm comparing with the brain, it has more density. In CT, there are density differences. So if I measure the density of hemorrhage, it is somewhere around plus 50 to plus 70. Okay. So this is a convex extraaxial or epidural hematoma. It has a lucid interval, means patient initially becomes unconscious because of the brain contusion, then recover. It looks like patient is normal, but the bleeding is going on. It is having expanding hematoma. So the lucid part is patient is okay, and then again collapse. So important is to identify initially, because once it is like expanded, it is already having complications. Compression of the brain, compression of the vessels, basal cistons, foramen magnum effacement. So it is having a bad prognosis. So as soon as it is identified, the neurosurgeon should be involved. Okay, so this one is extraaxial or the epidural hematoma. Here can be subdural, this one as well. Okay. Now in these images, you can see subdural hematoma as a crescent appearance, as a concave appearance. So epidural is convex, subdural is concave. Okay. Now you can see very clearly that this is like from the right frontal to parietal region. Okay, and it is having a mass effect. How can you identify the mass effect? You can see effacement of the ventricle. This black area is the ventricle. This is the normal ventricle. Okay, this one is compressed. And if I draw a line from the midline, and then, okay, it is showing midline shift to the left side. Whenever there is midline shift to one side, there are chances that it is causing compression of the vital structures, especially the vessels. Something is like maybe connections. Okay, so subdural is like a banana appearance. It's not coming. Maybe with this having crop.
No, it should be good, but maybe. Oh, this is not on. Okay. Anytime maybe it glitches, try pressing this one. If it takes a long time to work, try pressing like this button here.
Okay.
Okay. If it glitches.
So, this one is subdural hematoma, epidural. So this looks like a lemon and this looks like banana. Now, what is this? Which type of hemorrhage is this one? No. See the left side, it's very clear. These sulci having CSF, but here it is hyperdense. So it is subarachnoid. Okay. So these images are showing subarachnoid hemorrhage, and on this image with the arrow, it is subgaleal hematoma outside the skull. Okay. As soon as we see any soft tissue skull injury, we must make a bone window settings to confirm if there is any skull fracture or not. In these two images, we have multiple type of hemorrhages. So if I see this one as a concave appearance, this one is subdural, this one is also subdural. What about this one? Epidural. And this is like a linear subarachnoid, and this one is parenchymal contusional hemorrhages. So all present in these two images. There is one condition known as tension pneumocephalus, and it is like a Mount Fuji sign. Here it is like it is expanding air into the subarachnoid space, and it is causing compression of the brain. It is like a one valve mechanism, and it needs urgent intervention. Apart from the trauma, whenever we do skull X-ray, we can see a lot of other diagnoses as well. It may be infection, it may be trauma, it may be neoplastic, it may be metabolic, it may be endocrine, or whatever. So if you see the first image, this skull is enlarged. This ballooning of the pituitary fossa or enlargement of the pituitary fossa. The sinuses are also enlarged. This mandible is having a different angle, which is known as prognathic jaw. This is typical for acromegaly. In this image, multiple small lucencies of variable sizes seen throughout the skull. I have 2 or 3 differentials. Either it is multiple myeloma, it can be metastasis, or it can be hyperparathyroidism. For hyperparathyroidism, we should have like a typical salt and pepper appearance. But this type of lucencies with well-defined margins, these are typical for multiple myeloma. Here a single lucent lesion with a small sequestrum here can be infection, can be Langerhans cell histiocytosis. In this image, these two images actually, we have like widening of the diploic space. Outer table, inner table. See this one? It's very small, but here it is widened because of the extramedullary hematopoiesis. And there is like hairbrush appearance. Okay, so this is typical for thalassemia. Now, these two X-rays of the face or skull showing extensive destruction of the frontoparietal bone with multiple septations and sclerosis. And when we did the chest X-ray, it's like a soft tissue mass in the superior mediastinum or thoracic inlet, leading to tracheal deviation to the right side. So this was a thyroid malignancy with metastatic disease. I showed these images to you just to give you an idea that when we are doing any imaging, there are so many differentials in our mind, and we have to be careful in evaluation, and we should have some checklist and some points to narrow our differentials, but ultimately we need a very good history of the patient. Okay, unless we are not collaborating or coordinating with the physician, sometimes either we overcall the disease or maybe we miss the findings. Then there are 3 types of facial fractures. These are Lefort 1, 2 and 3. I will not go into details, just want to emphasize 2 or 3 points. You know about the pterygoid plates. If the pterygoid plates are involved or fractured, one side or the other side, or both sides, and with fracture of the facial bones, we call it as Lefort. So how to remember? The simple thing is, just remember that when we have zygomatic arch fracture, this is Lefort's 3, other than involvement of the maxilla, inferior orbital margin, nasal bones. But if zygomatic bone is not involved, this is not Lefort 3. If it's involving the inferior orbital margin, not involving the zygoma, this is 2. Okay, and if it's below only the part of the maxilla, inferior nasal margin, this is 1. So it's difficult sometimes if we forget, but easy to remember at least 1, which is 3. So third is like pterygoid plate and the zygomatic bone fracture. Then you can think, okay, what is less than the zygoma is inferior orbital, so it's 2. So if it's least, it is 1. Okay. So 1 is like the floating palate, then the floating maxilla, and then the floating face. Okay. The another fracture is like known as tripod fracture, in which pterygoid plates are not involved, but zygoma is involved, frontozygomatic suture is involved, maxillary sinuses are involved. So it's like multiple complex fractures. One of the name is like tripod fracture. Now this is nasal bone fracture. So lateral view of the nasal bone. Just remember, whenever you have any patient with suspected nasal bone fracture, do both lateral views, because we have 2 nasal bones, right? And 1 nasal septum. Clear? So this one is the nasal bone lateral view. I can see a fracture here. This is the 3D reconstruction of the nose. Again, we can see fracture on this one side of the nasal bone. And this is coronal image, single image. Here we can see fracture on the left side with depressed margin. Okay, you can see 2 bones here. This means it is depressed. Okay, regarding the mandible, like a skull, we can have fractures. We can have simply root canal abscess or apical cyst, amyloblastomas, multiple myeloma, brown tumors, dentigerous cyst, which is involving the crown of the tooth, temporomandibular joint dislocation. So we can have multiple pathologies related to mandible and TM joints, okay, apart from rheumatoid arthritis and the arthritis and dislocations. So important is this area. So this one is the condylite process, coronoid process, ramus of the mandible, body of the mandible, and this is angle, okay, and this is part of the body. So most fractures at the body and the angle of the mandible. Here you can see the body of the mandible fracture here. This one is at the angle. So if you see any fracture of the body of the mandible, try to see if it extends to the alveolar margin or not, and maybe it is causing tooth fracture as well. This is 3D reconstruction. So this is a coronal image. What you can see, it's a fracture of the condylite process, and this one also, and with dislocated fragments. Okay. So what can I do again? Okay. Maybe it will just come by itself. Okay, so now here you can see one important point. This is the temporomandibular joint. For the assessment of TM joints, we can have open and closed mouth X-rays, open and closed mouth, even MRI for the assessment of the articular disc. So in open mouth position, this condyle move anteriorly up to the anterior margin here, but in closed mouth it should come inside the joint. If it's not, this is TM joint dislocation. These are the different pathologies involving the mandible. Another pathology of the mandible is like a large expansile lesion with a ground glass density with septations. This is on one side of the face, and it is because of the fibrous dysplasia. Then comes to the orbit. So if you see these images, you can find out multiple findings. On the first image on the left side, it's like periorbital swelling, so it's cellulitis. So if you remember from our previous discussion that we have discussed about the different spaces, I will spend few minutes on this point because this is important to remember it. So we have like cone, which are the muscles, right? Intraconal, inside the muscles, extraconal, outside the muscles. For example, lacrimal gland is outside the muscle. Periorbital is outside the cone, so it's extraconal, right? So here, if you can see this image on the left side, top, this is periorbital cellulitis, this is intraorbital cellulitis, but it is still extraconal, okay? It is anterior to the muscle lateral rectus, adjacent to the eye globe. On this image, this is subperiosteal inflammation with a small abscess formation. So if patient has orbital cellulitis, the complications are it can erode the bone, and then it can cause maybe like restriction in the diffusion weighted sequence, and which is basically related to subdural empyema. If you do the post-contrast images, there is thick enhancement of the collection. Now, this is a foreign body in the eye, right orbit or right eye globe. What is important in this image, that it is not extending to the optic foramen, okay? Maybe I can remove my USB, so maybe that can help.
No, it's all right.
But the point is, it's coming. Okay. Is this better or this one? Same. Okay, leave it. So this is like a foreign body nail in the right eyeball, and it is not extending towards the optic foramen. Okay, this is a patient post-trauma. I want you to just see the image and try to identify the pathology. Although it is already marked with yellow arrow, so there is something here on the inferior margin of the orbit. On the right side, there is nothing like that. And then we can have on the CT, there is defect here in the inferior orbital margin with extension of the orbital fat inside the maxillary sinus. So what is the name of this diagnosis? Anyone? I think I've discussed this before. Blowout fracture. Okay. So whenever there is floor of the orbit fracture or inferior orbital margin fracture, and if it is extending inside the contents, it is called blowout fracture. Okay. Now these three images, you can see there is thickening of the medial rectus muscle more than the lateral rectus muscle, but the significance is the body of the muscle or the bulk of the muscle is enlarged, but not its tendon insertion. This is known as Coca-Cola sign or Coke bottle sign actually, and it is called because of the Graves' disease. This is the same finding. This is to measure the exophthalmos, but here you can see the bulk of the muscle in the medial rectus is enlarged, but the tendon is not involved. If the tendon is involved, this can be seen in cases of pseudotumor or inflammatory process, not Graves' disease. Okay. Now this is an intraocular foreign body. Within the eyeball, there is a foreign body here. We have to be careful to assess if it's a lens dislocation or a foreign body. So this is not a lens dislocation. Lens is present in its place, but the foreign body is present posteriorly. Now, leave this diagnosis, but where this is located, this is intraconal or extraconal? Anyone? Intraconal, because it is within this cone, within this muscle area, retroorbital fat. So this is like capillary hemangioma of the retroorbital space. This is an image of the thyroid gland. Here you can see the thyroid is enlarged with significantly increased vascularity. It is known as thyroid inferno, or maybe like a snowstorm appearance. So you can see a lot of vascularity and with enlarged thyroid, again a case of Graves' disease. Then comes to the neck part. We have this image of normal palatine tonsils location. Here also normal palatine tonsils, oropharynx here, epiglottis this one, cricoid and thyroid cartilages here. So what you can see in this image, this is axial T2 weighted image, where you can see enlarged tonsils and they are just closing to each other, known as kissing tonsils, and it is causing narrowing of the oropharyngeal airway. So this is tonsillitis. But in CT scan, we can find there is a collection in the left tonsils with thick peripheral enhancement. This is tonsillar or peritonsillar abscess formation. Another patient, age 2.5. So just remember 2 points. If something related to upper respiratory below 3 years and more than 3 years, so age is important. If it's below 3 years with distended hypopharynx and with narrowing of the trachea, this is known as croup. If it's more than 3 years or 4 years, up to 6 years, if it's like thickened epiglottis, this is epiglottitis. One needs supportive management. The epiglottitis is like emergency. It needs very careful attention because it may lead to maybe some intervention like tracheostomy, etc. So this is known as a steeple sign. Here there is a narrow trachea here and with distended hypopharynx. And in this image also, lateral view of the neck, you can see distended hypopharynx and with narrowing of the trachea. In these two images, this is a normal epiglottis. Here you can see a thickened epiglottis. It should not be like this soft tissue thickening here. So if we see this one, this is epiglottitis. Okay. Important to remember, whenever you see a lateral view of the neck, and if I see increased retropharyngeal space, how I know that this is really genuine space thickening, or maybe just because of the positioning on normal soft tissues. If you measure the distance between the posterior and anterior margin of the vertebral body, the AP diameter, this soft tissue should not exceed this distance from here. So if you measure this distance, for example, this is 3 centimeter, let's suppose, or 2 centimeter, and here it is 3 centimeter, then this is abnormal. The other importance of this retropharyngeal airway or retropharyngeal space, is like if there is any abscess here, it extends, it is known as danger space, because normally the retropharyngeal space is not visualized, it's very thin. But when it is distended with pus or any infection or anything, or hematoma, it extends to the mediastinum. So it leads to mediastinitis as well. Okay. So like in this case, this is a retropharyngeal abscess, and this is a retropharyngeal abscess, and it extends to the mediastinum here. So the complication is mediastinitis and mediastinal abscesses. Now comes to the paranasal sinuses. Okay. So just to draw some lines here, forget about these lines, but this is nasal septum, just to recall your last session anatomy. Nasal septum, it is deviated to the right side with bone spur. inferior turbinate, middle turbinates, okay, maxillary sinus. This one, the same, this is a straight septum, turbinates, maxillary sinus, and this process, part of the osteometal complex. I hope you remember the name of this structure. If not, no, this structure. Turbinate is this one. This angulated part is known as uncinate process, and this gap is hiatus semilunaris. If this uncinate process is obliterated because of the position, because of the pathology, it causes obstruction of the maxillary sinus. Okay, so this important to remember that this osteometal complex is important for the clearance of the mucosal changes here. Now, in this image, the deviated nasal septum is towards the left side, and this is enlarged middle turbinate, and it is aerated. It is having air inside. This is known as concha bullosa. So this one is a coronal image showing deviated nasal septum to the right side. This is the left inferior turbinate hypertrophy, and this is enlarged concha bullosa. Same here. Okay, so this image, this is the lateral view of the nasopharynx. What we can see it here, enlarged adenoids. Okay, and it is causing narrowing of the nasopharynx. This one is palatine tonsils. Okay, and this one is the lingual tonsils. So enlarged tonsils as well as enlarged adenoids causing narrowing of the nasopharynx. Okay, so can anybody tell me about this diagnosis? Where is the pathology, right or left? Right side. So right maxillary sinus, and there is soft tissue here and with a straight margin. So this is air fluid level. So this is acute sinusitis. This one is expanded sinuses, completely opacified. There is no air here with hyperdensity, typically for sinonasal polyposis or fungal colonization. So complications of sinusitis are subperiosteal abscess, orbital extension, intracranial extension, abscess, subdural empyema, and sinus thrombosis. So, sorry?
Yes, which side is the obstructed side? Is it left?
Nothing is spared. All sinuses are involved. Yani, you just go back. Here you can see clear air inside, right? There is no air. All replaced with soft tissue, inflammatory granulation tissues, as well as inspissated secretions, and like the fungal element as well. Okay, so in this patient we have like this Pott's puffy tumor. This, because of the frontal sinusitis complications, we have subgaleal or outside these skull bone abscess, and it extends inside at subdural abscess as well, or subperiosteal abscess. These are the MRI images with thick peripheral enhancement, and this one is basically the diffusion weighted sequence. Another image showing the left temporal lobe abscess because of the complication of sinusitis or mastoiditis. It is showing thick peripheral enhancement, collection, subperiosteal hair, and this is parenchymal collection or abscess formation, and this is MRV images where this is the left transverse sinus, and this one is right transverse sinus, and it is showing thrombosis. This is important to remember that patient is having this tumor, which is most common benign nasopharyngeal tumor of all head and neck tumors, age adolescent, 15 years, highly vascular tumor. If you remember from the previous discussion, these are the pterygoid plates. This one is pterygomaxillary fissure, okay, and there is a mass here. and here also is sphenopalatine foramen. So it's a highly vascular tumor at the sphenopalatine foramen involving the pterygomaxillary fissure, and it is juvenile angiofibroma. What is the significance of this? You should not biopsy this lesion because it is highly vascular tumor. It leads to bleeding. So first we have to make intervention, embolize the lesion. Once you reduce the vascularity, then make the biopsy or surgical removal. Okay, so this one is like a foreign body in the esophagus or trachea. So one view, for example, this view, we are not sure where it is that. So we have to take the lateral view. In this image, likely it is in the trachea, but we have to take it again. Now in this image, you can see a foreign body, a coin, but if you do a lateral view, this is trachea, which is present anteriorly, and this one is esophagus. So this is present in the esophagus. Either it passed down or maybe it requires immediate endoscopy for removal. This is a nasal foreign body on the left side. Okay, again, if you see this only one view, don't trust on one view. This is a message. Try to ask for the another view. So do a lateral view. If it's there, fellas, if it's maybe in the soft tissue, in the skin, or maybe like any jewelry or something, it can be visible. Okay, now we can just have few quick cases for some discussions. So I want you to participate and you should tell me the diagnosis. We have got 5-10 minutes easily. So this is the first image, a case of trauma. Although it is already marked in the right side, there is something here which is not present on the left side. There is a mucosal thickening in the right maxillary sinus. So what is this pathology considering the history of trauma? But maxillary sinusitis can be this one. It should not be this one. Okay. This is on the inferior orbital margin. Blowout fracture. It's a typical teardrop appearance. Okay. So somebody is just crying from one eye. Okay. Unless it's a double blowout fracture. Now, this is axial T1 weighted image. My question is, where is the pathology? Intraconal, conal or extraconal? Extraconal. What do you mean by that? Where is the pathology? If it's extraconal means outside, right? Outside the cone. I cannot identify anything outside the cone. So where is that?
It's at the right side. It looks like
Okay.
it could be a hemorrhage of the cranial hemorrhage.
No. Leave this bone, brain part. So this muscle is medial rectus. This one, lateral rectus. This one, optic nerve. So this muscle is asymmetrically enlarged. This is medial rectus. Like this is a Coke bottle sign, right? So now, where is the pathology? Intraconal or extraconal?
Intraconal.
Conal. So it's a Graves' disease with enlargement of the bulk of the muscle, okay, and sparing of the tendon. Okay, in this image, what is the diagnosis? First, what is the finding? Air fluid level. So this means it is acute sinusitis. Okay, which hematoma is this one? Epidural hematoma with fracture of the right parietal bone, and it is depressed here. Okay. So this is open and closed mouth views. Only basically this is a closed mouth view for both TM joints. So this is the left one with normal condylite process in the articular space. But here what happens? It is outside. It is not inside this joint. So this is dislocated. dislocated temporomandibular joint. Okay, this is most simple. Lateral view of the neck showing nasopharynx. This is a pediatric case with snoring and obstruction. So what is this structure? Adenoids. So this is enlarged adenoids causing narrowing of the nasopharynx. Okay. Now, in this view of the skull, we have marked two sutures. So which one is sagittal and which one is lambdoid? So the vertical arrow is pointing towards lambdoid and the midline is sagittal. Okay, so this is a nasal bone lateral view. Now this is the nasal bone and part of the nasal septum as well. So if you remember, the nasal bone formed, or basically the nasal septum is formed anteriorly by this cartilage, posterior superiorly by the perpendicular plate of the ethmoid, and posterior inferiorly by vomer. So this part is vomer. Okay. Now, question in this image is the arrow part is clivus. This is I am telling you. Okay. So maybe I can ask, or I can say, okay, what is this pointing arrow? So it is posterior to the cell, posterior to the pituitary fossa. This means this is clivus. So what is anterior to it is pituitary fossa. Clear? Okay. This area pointing towards osteometal complex. This aperture, which is going curved like uncinate process. This one is uncinate process, and there is hiatus sabellinaris. If this osteometal complex is blocked, which sinus is affected? Maxillary sinus. Okay. This arrow pointing towards which structure? These are muscle bell, optic nerve, eyeball, lateral superior lateral is what? Here. Lacrimal gland. Lacrimal gland. So lacrimal gland is intraconal or extraconal? Extraconal. Thank you.
Thank you, Dr.